Good afternoon and welcome to Dental XP. My name is Dr. Richard J. Martin, oral and maxillofacial surgeon in Dallas, Texas. I'd like to thank the folks at XP for inviting me to present on my topic. Today I'm going to discuss the management of congenitally missing teeth. Where are we now? This is going to utilize the concept of small diameter implants and basically my evaluation of how to get to this point. Many children today present to the pediatric dentist, orthodontist, with one or two, sometimes even more, missing teeth. We're faced with the challenge of how to manage these spaces through adulthood when implants can be placed. How do we take a kid that we first see at 10 years old, 8 years old, and get them to this point where we can have a tooth number 7 that looks very natural? What happens when we see a situation such as this one where we have several missing teeth that was caused by a complex odontoma? How do we manage this child to get them to the point of placing dental implants? Well, the purpose today for the management of these teeth is let's look at the evaluation. When can we see missing teeth? Or can we identify them as soon as 2 or 3 or age 5 or 6? When do we see supernumeraries? As an oral and maxillofacial surgeon, often I get referrals from the pediatric dentist for the removal of maxillary mesiodens, and that comes anywhere from age 4 to 10 or 11 based on the development. Well, when we look at congenitally missing teeth, we should approach it as a team, as we do in cleft surgery. We should have a pediatric dentist who is usually the first to recognize the tooth. We have the involvement of orthodontist, restorative dentist, and a surgeon. We want the early evaluation to make sure we see why is that tooth missing. Is it because there's just not a tooth bud, or is there some obstruction that's causing that tooth not to develop? So we have to get a game plan together. We have to assess the site. Is it maxillary mandibular missing teeth? Is it premolars? We all know that maxillary laterals are the most commonly found tooth to be congenitally missing, and we have to evaluate the space utilizing several different means. Is it the golden proportion? Do we look at the contralateral incisor, or can we use Bolton analysis? All these have been widely advocated by Dr. Vince Kokich, who has done quite a bit of work on the management of congenitally missing teeth, when to treat, and how to treat. And all sources say that early referral to the surgeon is critical. Now, when we get to the point where these children can be treated, we want to make sure that we have adequate root alignment and adequate space. Usually 5 to 7 millimeters is adequate in order to place a small diameter dental implant. In the past, the smallest implant that we had was a 3.5 or 3.25 implant, but on the market over the last several years, or several manufacturers have come out with a 3.0 diameter implant. So we take a look at this case and we see where we have multiple missing teeth, and both laterals, centrals, and even molars. But what we most commonly see is a situation like this, where we have missing teeth number 7 and 10. And how do we get to this point? How do we orthodontically align the teeth orthodontically align the teeth to get to this position? Well, many times we see that we have retained cuspids or retained laterals. Now, what we look at is a crown of the developing permanent canine is usually positioned apical to the root of the primary canine, and what has been advocated is taking this canine and erupting it into the lateral position and then distalizing it. Again, many of these principles by Dr. Vince Kokich in Washington. We want to create an alveolus in a missing tooth situation. And again, if they're still in the erupting stage, we can encourage the development of the alveolus through orthodontics. Now, the diagnostic workup is most predictable plan. We have to determine the space. What about a cone beam scan? Well, in today's market, cone beams are everywhere. They can be very useful, and they can give us a good idea of what is the alveolar thickness. Is there any unknown defects within the bone that may create a pitfall? And it can tell us whether or not we need to bone graft. Now, once we have the patient in orthodontics, and we have to keep them there at times for many years in order to hold the space. So typically, if we see a patient that's 12 years old, we know that surgically we can't place implants on that child for 4 years, 5 years, 6 years, both based on the growth. So we have to utilize removable partials, resin bonded bridges, fixed bridges, and most recently the use of mini implants has become popular. We know that single tooth implants are the least invasive because they do not require tooth preparation. So the remainder of this lecture will concentrate on what do I do, what's my technique, what's my utilization of dental implants in these areas. Now, graft versus no graft, depth of placement, position buccolingually, the adjacent roots. These are all things that we must consider in placing these small diameter implants because, again, these are 5 to 7 millimeter spaces, and the projection of the implant from the alveolus is critical, as well as the position to the adjacent teeth. We can utilize Simplant to evaluate the bone, as I previously mentioned. So how do we get to a point like this? Well, we look at this space for congenitally missing number 7, patient still currently in orthodontics. However, this is quite a large space, and if you take a close look, we really don't have any papilla development. So let's look at how can we shape papillas. We can use a pontic and essentially make that pontic the size of the tooth that we would like to replace, and basically narrow down the space to that size. We must have close contact with the orthodontist in order to get us to this point. So now this patient is ready for implants. However, we do have a slight buccal defect, which we can manage at the time of surgery. So we have nice alveolar thickness, adequate alveolar thickness. This is very critical in placing the buccolingual positioning of the implants. And as we all know, that palatal placement for maxillary implants is preferred. So surgical guide, twist drill, implants are in place, and we're going to plump out the buccal with just some particulate bone. Here you see nice positioning, buccal plumping. Now, another area that we have to look at is, do we need to soft tissue graft these sites also? Do we need to bulk them out with just bone, or do we need bone and soft tissue? And again, that's a clinical decision. Just a subepithelial or free gingival graft works well in these areas. At times, in my hands, I like to cover the actual site. If at times we will retain primary laterals to hold the bone, and when we extract these laterals, we're left with the opening, and so I like to soft tissue graft these sites also. So once the implants are placed, we utilize again some form of a removable prosthesis, or we could immediately temporize depending on the situation. So here you see the final case, implants in place, zirconia abutments and final crowns, teeth numbers 7 and 10. Now let's transition to the use of small diameter implants, mainly 3.0. Here we see the Astra OsseoSpeed 3.0 that has a micro threads at the coronal portion and a more aggressive thread pattern at the apical. And this is a good implant for these 5 millimeter spaces. We follow our rules of having at least 1.5 millimeters on either side. Again, what this does is, in times when we would try to place larger diameter implants and really squeeze them in, even if we have 6 millimeters between the teeth now, we can still utilize a 3.0 implant and still have adequate spacing on either side so that we don't interfere with the adjacent roots. So we look at placement here and the utilization of provisional abutments. I like to go to provisional abutments prior to final and utilize a technique to help to shape the gingival margins. What you see here is a technique of basically just taking acrylic teeth and trimming down the cervical portion, making it more of a concave to have it snug under the tissue and help to shape. So here you see the technique being utilized. Again, if you closely look at tooth number 10, you'll see where there's a little bit more preparation of the cervical portion, and this is going to slide underneath the gum tissue in order to shape the papilla and support the facial tissue. So again, 7 and 10, these are gold hue abutments with provisionals. You see adequate spacing and excellent bone around the implants. Now, when we go to our final, this is the Atlantis CAD/CAM technology. Really nice way to finish a case and to get accurate design for the positioning of the abutment. So here you see the gold hue. They can be customized, and when we utilize the gold hue, it really does help with the color and the final outcome. Now let's look at centrals and laterals. Many times in the mandible, we may have congenitally missing central incisors, and orthodontically, the lateral incisors are mesialized, and what that does is provide bone in the lateral position. In my hands, I would prefer to place implants in the 23 and 26 position rather than 24 and 25. And in doing that, in mesializing, or like I like to call it, centralizing the laterals, that gives us good bone deposition and allows us to come back and place the implants. So here you see a case of an adult patient that was congenitally missing the centrals, and the laterals were mesialized, and then she had a resin bonded bridge fabricated that had been replaced 3 or 4 times over the course of her life. So what we decided to do is, well, let's try to get some bone in the lateral position to place the implant. So as you can see, clinically, the case looks, great. Patient has teeth. However, if you look at the position of the roots, they would be in the direct interference with placement of implants. So place the patient back into orthodontics, mesialize the roots, giving us adequate space to place the implants. So 3.0 asterosteal speeds were utilized in the 23 and 26 position. We used opaque titanium abutments. Here you see the provisionals, again, to shape the gum tissue. And we will let these provisionals shape the tissue for 6, 12, 16 weeks until we feel the tissue is in an optimized condition. Let's look at the utilization of block grafts and alloderm in a situation where we are missing teeth numbers 24 and 25, and there was not the possibility of mesializing the teeth. You can note the buccal defect. So what we're going to do here is bone graft. So this is post-graft. I did a symphysis or chin graft, and you can see here with I like to leave the screw in place while I'm placing the implants. I try to place the screw directly in the midline so that I can guide me when I come back to place my implant. So here you see we're going to come back and place the implants. We're going to pack a little bit more bone around the particulate bone around the site. utilize alloderm to thicken the tissue in what I like to call an alloderm blanket form. Suture, come back at about just approximately 4 months after. We're going to take some fixture level impressions, fabricate zirconia abutments, provisionals the same day, and then final crowns. This patient went ahead and had the 4 mandibular teeth restored at the time. Let's look at a complex, comprehensive case. This is a young lady that was referred to my office. She was basically born with a cleft palate that had been repaired, and in these cleft patients, they will at times grow to be class 3. As you can see here, there's deviation of the chin to the right, slight open bite. So we placed her in orthodontics, and she was missing the central incisors. So again, after I did a Lafort osteotomy, brought her maxilla forward, did bilateral vertical ramus osteotomies, rotated the mandible. Patient elected not to have a chin done at the time. So once the maxillary surgery was healed, we went ahead and started the implant reconstruction and decided that we were going to try to keep those centrals, move the laterals into the central position to create bone. However, we still had a bone defect there and got a little splaying of the teeth. So we went ahead and did another symphysis graft, and what was done was I used 2 what I call chiclet grafts, where I did a symphysis graft, separated it into 2 separate blocks and lagged it to the mandible, and again used membranes and additional particulate bone. You can see the screws coming through the tissue. That is fine in these cases, as long as it's not erythematous and there's no infection. I tend to leave them and again take them out at the time of placement. I try to utilize my twist drill and drill to depth so that I can see where I'm placing my implant. Then I'll remove the screw. This also helps in making sure that the segment is stable. So here you see implant placement. And the slide on the right, you see the bone plates and the implants restored. Okay, the laterals, again, patient elected not to have any further work, any further restorations. She's 22 now, very happy, and came in to see me to finally have the chin done. My name is Dr. Richard J. Martin, Dallas, Texas. I'd like to thank Dental XP. Please check out my expert page for additional presentations and articles, or if there's a need to get in touch with me. Thank you.